आम्ही तिथे परत का लिहून ते युट्यूब म्हणून आपला युट्यूब नको होता ना.
हाँ सर.
ते परत लिहिलं होतो ना लाईव्ह ऑन युट्यूब म्हणून.
हाँ.
काय काही नाही का, काही ऑल्टरनेटिव्ह काही नाही आहे का?
नहीं है सर.
हम्म. आम्ही तिथे परत का लिहून ते युट्यूब म्हणून आपला युट्यूब नको होता ना. ठीक आहे ठीक आहे ठीक आहे. आम्ही तिथे परत का लिहून ते युट्यूब म्हणून आपला युट्यूब नको होता ना.
हाँ सर.
ते परत लिहिलं होतो ना लाईव्ह ऑन युट्यूब म्हणून.
हाँ.
काही नाही का, काही ऑल्टरनेटिव्ह काही नाही आहे का?
नहीं है सर.
आम्ही तिथे परत का लिहून ते युट्यूब म्हणून आपला युट्यूब नको होता ना. ठीक आहे ठीक आहे.
सोमेश्वर
अमित, हा, आय एम हिअरिंग दॅट अगेन अँड अगेन.
हा आणि
युट्यूब म्हणून आपला युट्यूब नको होता ना. अमित,
अमित अमित
हाँ सर.
वाय देयर एन एको.
मला माझाच आवाज परत परत ऐकू येतो हा 2-3 वेळेस.
मी केला केला बंद केला.
ऑल्टरनेटिव्ह काही नाही आहे का? परत ऐकू येतो मला तर परत.
नहीं है सर.
आम्ही तिथे परत का लिहून ते युट्यूब म्हणून आपला युट्यूब नको होता ना. ठीक आहे ठीक आहे.
सोमेश्वर
अमित, हा, आय एम हिअरिंग दॅट अगेन अँड अगेन.
हा आणि
युट्यूब म्हणून आपला युट्यूब नको होता ना. अमित,
अमित अमित
हाँ सर.
वाय देयर एन एको.
मला माझाच आवाज परत परत ऐकू येतो हा 2-3 वेळेस.
मी केला केला बंद केला.
ऑल्टरनेटिव्ह काही नाही आहे का? परत ऐकू येतो मला तर परत.
नहीं है सर.
आम्ही तिथे परत का लिहून ते युट्यूब म्हणून आपला युट्यूब नको होता ना. ठीक आहे ठीक आहे. सोमेश्वर अमित, हा, आय एम हिअरिंग दॅट अगेन अँड अगेन.
हा आणि
युट्यूब म्हणून आपला युट्यूब नको होता ना. अमित,
अमित अमित
हाँ सर.
हा हॅलो अमित, कॅन यू हिअर मी.
हाँ डॉक्टर भरत.
हा आता ते बंद झालं. इट वॉज काइंड ऑफ अ लूप रेकॉर्डिंग होत होतं. ते सेम
नाही
थिंग
नाही
वॉज.
ऍक्च्युली डॉक्टर रेणूकडे ते ऑन होतं
हा
माईक
हा
पण आणि ते लिंक पण म्हणून.
ओके ओके थांबा सोमेश्वर मला
केलं.
कॉल
हा
करतोय.
क्लोज केलं हो.
केलं ना ओके.
Yes, yes. हो.
हॅलो.
हा सोमेश्वर.
हा, अशी मी तुम्हाला कॉल करतो मी. आय जस्ट
हा हा काय नाही ते एकोईंग आणि
इकोचंच ना.
हा ते रिपीटिंग बंद होऊन गेलं. आय थिंक देयर वॉज सम टेक्निकल ते अमित हॅज रेक्टिफाईड.
Yeah. Hopefully it will not come again.
Did you speak with Saugata?
He's joining. He joined 10 minutes.
Joining, na? Okay.
Mhm.
It's now 5:45. I will just pin Professor Estes.
Good evening, sir. Sir, you're on mute. Yeah.
अभी तो जस्ट सेट करा था, अभी टाइम कहाँ हुआ था
अच्छा
यार।
अच्छा. Yes,
चलो
yes, yes.
चलो, मैं एक स्कैन करूंगा, फिर आऊंगा, फिर ज्वाइन करूंगा, ठीक है।
Fine, fine. Yes, sir. Yes, sir. Thank you, sir. Thank you.
Hello, good evening, sir.
हाय भारत।
I just spoke with Professor Steves. He's going to join in 5 minutes.
ओके, परफेक्ट परफेक्ट परफेक्ट।
Sir, one participant, Dr. V. Sujata, she has some cases. So she has shared some 3 cases. So I have asked her to directly unmute and directly talk to Dr. Steves.
एब्सोल्युटली एब्सोल्युटली।
So she has 3 cases. Sir, so depending on time, sir, you can take the charge.
एब्सोल्युटली। नहीं, वो परफेक्ट है। अगर कुछ लोग खुद से बोलते हैं तब तो बेस्ट है ना।
Yes, sir. I asked them to unmute and just talk directly.
ठीक है, तो लेट मी जस्ट कम बैक एंड जॉइन आफ्टर द स्कैन, ठीक है।
Okay,
कनेक्शन
sir.
चालू रहेगा।
हाँ जी, sir. Yeah. Thank you.
আপনি এদিকে চলে আসতে পারেন, ব্যাকগ্রাউন্ডটা ব্লার করে দিয়েছি। হুম হুম।
Good morning, Professor.
Good morning, Dr. Bharat. How are you?
Good morning, Dr.
I'm
Professor.
fine. So,
Good
Professor,
morning.
yeah, my colleague Someshwar is going to start the meeting today from Merck end. He's my colleague, Someshwar Raisam, Dr. Someshwar
Yeah.
Raisam.
Good morning,
Yeah.
Professor.
How?
Yeah.
Good morning. How are you?
I'm good. We met during ISAR in 2019 at Mumbai.
Yes, I remember that.
Yes, yes.
Okay.
So do you want me just to share my screen to make sure that it's working fine?
Yes,
yes.
yes.
Hold on. So can you see the screen with the slide, the first slide?
Not yet.
Not yet. Not yet.
Yes.
Yes. Perfect.
All right. So I will stop sharing now.
So all looks good. So Professor Steve, Dr. Gudgutia is joined, so he would be our chairperson for the day. He has just gone for a scan, so he will be back very soon.
Okay.
So we're expecting around 20 participants today from India and one from Nepal and one from Sri Lanka. And we're looking forward for a good discussion tonight.
Excellent. So you are organizing these meetings well.
Thank you. Thank you so much.
I enjoyed participating in the first one.
Yeah, good to know that. Yeah, Dr. Rohit is back.
Yeah, I'm back. Yeah.
Hello, good morning, Dr. Rohit. How are you?
Yeah, it's a pleasure, and it's my honor to kind of get to talk to you today. I have been following your career very closely. We had time to see you, I think, in 2012 or something. So I really look forward to today's evening.
Thank you.
What is it now? How's COVID in Brazil now?
COVID is much better. We are having, just few cases reported, and also deaths are pretty low numbers. The vaccination is kind of everywhere.
Okay.
Still some cases, but basically life is back to normal in most circumstances. Only hospitals, they are still asking people using masks, but apart from that, it's basically everything back to normal. How is it in India now?
Yeah, much better, much better. In my part of the country, we are completely normal now. Not wearing the masks also.
Even in the clinic?
Even in the clinic, we have stopped using
clinic.
masks. Yeah, absolutely.
And
how's work? Work's come back to normal?
Work is, the Minister of Health, even for us infertility centers, they asked us to, reduce cycles, doing mostly, the most urgent cases, not actually doing cycles as regularly done. But now, the restrictions are gone, and we are operating normally. So, since I would say basically 3 months ago, everything is back to normal.
Perfect. And for today, what are you going to talk about? The criteria and anything else that you would be talking about today?
I will be discussing, what is new in terms of low prognosis patients under the scope of the Poseidon criteria, the validation studies that we have conducted and published, in particularly in human reproduction. I will highlight some of the studies that we published, validating, the concept of low prognosis, also the thresholds that we suggested to be used to classify Poseidon patients. And I will summarize what is available in terms of studies providing some management options for this patient. So I will provide some summary, and at the end, I will present what we do in the clinic in terms of, the treatment strategies that we use most frequently for these patients. So basically, it's kind of an overview.
You will be talking about the CBLR, and you will be mentioning the calculator also.
Yeah, I will mention briefly the calculator, how we use it in the clinic, but feel free to, open the discussion, the topics that you feel are more important for me to stress. I'm trying not to make the presentation very long, so if there's any topic that you particularly feel it's not so clear, feel free to touch on that, and then we discuss more, in more detail.
So because we will be having a freewheeling discussion post the talk, am I okay to get discussions on andrology, on LH, on quality control? Those topics are
Yeah,
okay?
feel free.
Okay, absolutely.
Yeah, absolutely.
Because
Absolutely.
you are very, very popular in this part of the world, and there would be
Thank
many,
you.
many questions that people would have to ask you.
Okay, no problem. Whatever you want to discuss, I will be available.
Fair enough. Somesh, we have 2 hours, right?
Yes, yes. We have 2 hours.
Okay.
We will have a hard stop at 8 p.m. IST.
Okay, fair enough. Perfect. Perfect.
So I think, sir, we have 15 participants joined. So should we wait for some time, or how, sir? How would you suggest?
I think for me, I think it'll be 6:05 and let's get started.
Yeah, perfect. Meanwhile, we'll send a reminder for all participants to join at least.
Please do that. Please do that.
Yeah. So, sir, should we start? Yeah,
Good to
thank you
go.
so much. So, good evening, everyone, and a very warm welcome. On behalf of my entire team of Merck, I, Dr. Someshwar Raisam, welcome you all for this EKTL meeting by Merck. The objective of this EKTL meeting is to enable our Indian fertility experts to interact with an international fertility experts for addressal of all their queries around different aspects of ART cycle. So today we are joined by Professor Santo ST from Brazil. He would be an international expert for the day, and we're also joined by Dr. Rohit Godgutia. He would be our honorable chairperson and monitor for the day. Now coming to the agenda for the day, after the brief setting of context by the moderator, Dr. Gudgutia, there would be a discussion and lecture on topic of managing low prognosis patients in ART by Professor Andrew STVs. And after that, the session would be opened for an open discussion on Q&A part, and all participants can ask their any queries and any related to any part of the ART cycle, and they can get their doubts addressed by Dr. Santo ST and Dr. Gudgutia. Today, we also been joined by elite panel of fertility experts from all across the country and also from Nepal and Sri Lanka. So today, we'll be joined soon by Dr. Aswati Nair from Delhi, Dr. Inu Makkar from Lucknow, Dr. Geeta Khanna from Lucknow, Dr. Sangeeta Sharma from Jaipur, Dr. Rita Bakshi from Delhi, Dr. Sophia Devi from Bangalore, Dr. Dash from Pondicherry, Dr. Divya Niranjan from Kanchipuram, Dr. Asha Rao from Coimbatore, Dr. A.M. Indira from Chengalpet, Dr. B. Sujata from Vijayawada, Dr. N. Sainial from Kolkata, Dr. S. Patnaik from Roorkela, Odisha, Dr. Narmada Katakam from Hyderabad, Dr. Colonel Nagaraj and from Pune, Dr. T.S. Palihavadana from Colombo will be joining us soon. Dr. Sadhna Patwardhan from Nagpur, Dr. Shruti Parikh from Mumbai, Dr. Vijay Pawar from Solapur, Dr. Pandit Palaskar from Aurangabad, Dr. Shrutika Thakkar from Mumbai, Dr. Geeta from Kudalore, Dr. Visunita from Madurai, and Dr. Neha Homaigen from Nepal. So we welcome all the participants who have joined. Yeah, very warm welcome. Now, without any further delay, I'd like to introduce our Dr. Rohit Gurgutia, who would be our honorable chairperson for the day. Dr. Rohit Gurgutia, he's a medical director at NOVA IVF Fertility East and also for Bangladesh. He was previously clinical director at NOVA IVF Kolkata and Genome Fertility Clinic from Kolkata for 13 years in the past. He has graduated from Medical College at Kolkata in 1998, and he has been trained in IVF from Herzliya Medical Center from Israel. He's an avid quizzer. He has participated in mastermind series on BBC, and Dr. Gudgutia is an invited speaker in all national meetings like ISAR, IFS, AICOG for last 10 years. So with this, I invite Dr. Gudgutia and I welcome him, and I request him to kindly take the session forward. Thank you, sir. Over to you.
Thanks, Shomesh. So it's always a pleasure to come on board on this meeting because it really opens up our vistas, allows us to interact with the best in business. And today, really, it is our good fortune that we have with us the Dr. Sandra Esthus, who, for the benefit of my colleagues here who are there in the show today, is not only the head of Androfert, which is one of the leading IVF clinics in the whole of South America. He is also affiliated as the professor in the Department of Surgery in the University of Campinas. And all you can see, all his other credentials are there for you on the display. He is also the co-founder and one of the working group members of the Poseidon Group. And for all of us, Poseidon has been one of the game changers in the last 3-4 years, as we all know. He has been the recipient of the Alumni of the Year Award from the Cleveland Clinic for Reproductive Medicine and many star awards from the ASRM. His publications are too many, I think more than 300 if I'm correct. And he's authored more than 70 book chapters. Some of his, or rather I would say most of his publications in the last 5 years have been really, really very, very well followed across the world. In my mind, actually, the best introduction that I can bring on table for him is that he is one of the leading voices of change in the world of ART, and this is across the world. I have been following his career very, very closely for the last 7-8 years, and I'm much impressed with what he says and what he professes. He is one person who straddles the world of ovarian stimulation, andrology, quality management in ART, and clinical embryology with equal finesse and felicity. And this is something which is very rare, because you have segmental experts, but we hardly have holistic experts as Sandro. And for the listening pleasure of Sandro, the audience that we've been able to get together today is a highly carefully curated group of ART specialists. And I'm sure that today is a sparkling event. We'll have a great intellectual discussion and close up following the next 2 hours. For now, I invite you to bring your thoughts on how to manage low prognosis patients, what's new, and what is it that you are doing in your practice. Professor Sandro Esteves, the floor is yours.
So good morning from Campinas, Brazil. So foremost among all, I would like to thank all and each of you for taking time out and being here today. Thank you very much for the kind introduction. I'm really flattered by your words. I'm delighted to participate in this webinar. I miss my friends from India. I mean, meeting you face to face. And every trip I've made to India, I've enjoyed so much. I want to thank Merck for inviting me to present this update on the Poseidon criteria and what some of the studies that we have conducted recently, and also some insights on possible ways to better manage this challenging group of patients. So I hope you can see my slide, my first slide.
Yes, Professor. Yes,
Okay.
I can see your screen.
Thank you. So these are my potential conflicts of interest. And then I move to the agenda. This is the outline of what I'll be covering in the next, I would say, 30 minutes. Then I will interact with you as much as possible. So the first part, I will give you a brief overview about the Poseidon criteria. I will give you an overview of what we think low prognosis patients are and how we consider the endpoint to classify these low prognosis patients. I will also discuss the validation studies, clinical validation studies that we published recently to substantiate the clinical utility of the Poseidon criteria for low prognosis patients. And then I will discuss treatment options for these patients based on what we have published in the literature and also our clinic's preferences. So let's get started. The Poseidon group was created in 2015. This was an initiative of Professor Carlo Alvigi from Italy to discuss and elaborate practical solutions for the so-called low prognosis patients undergoing assisted reproductive technology. The Poseidon actually is an acronym that stands for Patient-Oriented Strategies Encompassing Individualized Oocyte Number. But Poseidon is an open group. It has now over 100 members from many countries across the globe, including India. So I invite you to consider joining us as a member. Information about the Poseidon group and how to join can be found on the Poseidon website. We have a website, which is www.groupposeidon.com. So anyone who wants to be part of the Poseidon group can join and take the benefit of what we offer. This year, for instance, we will have the first Poseidon Congress in Portugal in September. So we will be discussing all the achievements that we have made so far over these years. And we will have many Poseidon members from across the globe. This will be a face-to-face meeting in Portugal. I believe soon you will get more information if you are not getting this information so far in your, newsletters. But just to give you an idea, the group has worked on many projects over the last 6 years. But as you may know, the proposal of a novel criteria to identify and classify patients with low prognosis in ART represents perhaps the most remarkable achievement of the Poseidon group so far. So these criteria were introduced in 2016 with the primary goal of underlying differences related to poor or suboptimal infertility treatment outcome regarding oocyte quantity and quality, and possibly creating more homogeneous groups for clinical management and research. So the Poseidon criteria, what is it? It classifies patients with infertility undergoing ART into 4 groups of low prognosis based on female age, ovarian reserve markers, I mean antral count and or anti-Müllerian hormone. And we also take into consideration the number of oocytes retrieved after a standard ovarian stimulation, I mean conventional ovarian stimulation. We are not talking about minimal stimulation for the Poseidon. If the patient had that information available, I mean, in a previous ovarian stimulation cycle, so then we take the number of oocytes retrieved into consideration. So as you can see in this slide, groups 1 and 2 comprise patients with sufficient ovarian reserve markers. I mean, the FSH is 5 and above, AMH is 1.2 nanograms per ml or above, but who unexpectedly, because I mean, having these ovarian markers, we would expect a good number of oocytes retrieved, but unexpectedly, several of these patients end up having 4, I mean less than 4, or even suboptimal that we consider between 4 and 9 oocytes retrieved. I mean, after a standard ovarian stimulation with gonadotropins, I mean, using at least 150 international units per day. And then we have groups 3 and 4 that include patients with a low ovarian reserve. So we know that these patients have expected poor ovarian response to gonadotropin stimulation, no matter what we do. But these patients are further classified according to age cut point of 35 years into young Poseidon patients. I mean, groups 1 and 3, these patients' age are below 35 years old. And then we have older Poseidon patients, I mean, groups 2 and 4, who are the patients aged 35 and older. So another thing that is important is that we can have a control group of non-Poseidon patients. I mean, patients with good ovarian reserve markers and normal response to ovarian stimulation, let's say over 9 oocytes retrieved. These patients can be classified as having normal prognosis, making the non-Poseidon patient group. That will be important later on when I will be discussing the clinical validation studies. This non-Poseidon group will be valid for comparison purposes. But if we can summarize what we have in terms of the Poseidon criteria, this slide can give you some glimpse of what we believe the patients looks like. In groups 1 and 3, we have young patients, and these patients, because of the age, they have a relatively low risk of having aneuploid embryos. And then on the other side, groups 2 and 4, they are older patients. These patients have increased risk of embryo aneuploidy. But in all groups, the number of embryos generated is likely to be low. That will affect the cumulative delivery rate per initiated or aspirated IVF-ICSI cycle. Poseidon considers ART in terms of IVF-ICSI, not IUI. So, but each group, each Poseidon group is supposed to have distinct reproductive outcomes based on age and number of oocytes retrieved. This was the criteria that have been proposed. And although it makes sense from a theoretical point of view, there was a need to validate its clinical utility. And for that, we have new data from at least 3 large-scale studies that I will share with you. These studies were possible thanks to collaboration that was made between our group in Brazil, the group of Professor Hakan Yaralis in Turkey, and also Professor Lam Vuong's in Vietnam. I mean, both the three centers are very busy IVF centers in their respective countries, doing many cycles per year, over 1,000 cycles. The group from Vietnam, they do approximately 7,000 cycles per year. The group of Professor Hakan Ziarali perform over 2,000 cycles per year. And one thing about these groups is that they have implemented a quality management system, and they systematically collect data using electronic medical records. So we have, I mean, a lot of information that we can extract and then evaluate. So the first study that we did, we wanted to answer the question of how often we find Poseidon patients in our clinics. So this is, I mean, a relevant question, because you can say, well, I think this criteria does not represent my patient population. So we wanted to know what is the prevalence of Poseidon patients in routine clinical practice. So for this study, we included over 13,000 patients. And we showed that the prevalence of Poseidon patients was significant. It accounted for about 43% of patients, I mean, treated in the participating centers. So here you can see the differences between our center in Brazil, Turkey, and Vietnam. There's some differences, especially when we consider if your center has older patient population, you should expect, as ours, actually a higher prevalence of Poseidon patients. In the Vietnamese center, for instance, the prevalence was 39%, and their average age of patients treated there was significantly lower than in the Turkish and the Brazilian center. So one thing that was very interesting in this study is that we found that among Poseidon patients, most of patients fit in groups 1 and 2. I mean, groups 1 and 2, if you remember, are patients that have sufficient ovarian reserve markers, but unexpectedly end up having poor or suboptimal response to conventional ovarian stimulation. And then we have groups 3 and 4 that accounted for about 20% of Poseidon patients, but the frequency of expected poor responders of older age, I mean group 4, was 3 times higher than that of groups 3. So this is interesting because, I mean, groups 1 and 2 are the patients who we have something to offer, because we could, I mean, adjust the ovarian stimulation protocol to kind of get the benefit of the ovarian reserve that these patients still have. Well, the other thing that we found in this prevalence study was that in general, the Poseidon patients were older, they had a higher BMI, lower ovarian reserve, and also higher frequency of any female factor as the primary treatment indication than non-Poseidon patients. So in this study, we compared also these aspects with non-Poseidon patients. And as I mentioned before, non-Poseidon patients were those with ovarian markers above the cut points established by the Poseidon criteria, and who had more than 9 oocytes retrieved after the standard ovarian stimulation with gonadotropins. But just pay attention that Poseidon patients required larger doses of gonadotropin for ovarian stimulation, despite achieving a 2.5 times lower number of oocytes retrieved than non-Poseidon patients. So the second study that we did was published last year in Human Reproduction in June, and we wanted to validate the clinical, the thresholds, the biomarkers, because we propose AMH and AFC as the thresholds, as the biomarkers to classify Poseidon patients. And then we defined it, AFC of 5 and AMH of 1.2 based on the literature. I mean, the ways to kind of distinguish patients with poor ovarian reserve. So based on what we had in the literature. But we needed to validate if these markers were indeed valid to classify patients under the Poseidon criteria. So we conducted a study to investigate these aspects. The study included over 9,000 patients, and all these patients had their baseline ovarian reserve assessed by both AFC and AMH. So in this study, what we found was that overall, 3 out of every 4 patients were classified under the same group using both biomarkers. So we did a study using the kappa agreement statistics, and we found that the kappa statistics was 0.8, which indicates a strong agreement between AFC and AMH to classify patients under the Poseidon criteria. So these biomarkers performed similarly with no apparent superiority of one over the other. But what is important is that some doctors ask, when we do Poseidon classification, is it critical to use both biomarkers, or we can use one or the other? Based on this study, in which 3 out of every 4 patients were classified under the same group using both biomarker, we can say that either AFC or AMH might be used for patient classification. So what we feel is that clinicians should adopt a single biomarker for patient classification, the biomarker that best fits your clinical settings. I mean, in our case here at Androfer, we prefer AFC because this is the biomarker that we have control. I mean, we are doing the ultrasound of every single patient, and we wanted to look into the ovaries to see what is the antral follicle count is for every single patient. So we don't combine biomarkers. If you combine both biomarkers for Poseidon classification, you should expect, I mean, 1 out of every 4 patients, about 25%, a kind of discrepancy between the biomarkers utilized, because 5 of AFC is more rigid than AMH of 1.2. And we can discuss more about that later on. But another very important finding from this study was that an AFC of 5 and an AMH of 1.27 were the optimal values to predict the retrieval of less than 4 oocytes. So these values actually were very similar than the values established by the Poseidon criteria. 5 was the threshold established for AFC, and 1.2 was the value established for AMH. So in this study, we showed 1.27, which is very similar than 1.2. And also, for the first time, we provided values, AFC and AMH thresholds, for suboptimal responders. I mean, patients who end up with a oocyte yield between 4 and 9 after the standard ovarian stimulation. So we found in this study that an AFC of 12 and an AMH value of 2.97 were actually the optimal thresholds for suboptimal site retrieval after conventional ovarian stimulation. Suboptimal retrieval defined as the retrieval of between 4 and 9 oocytes. So this is the second study I wanted to share with you. Now I want to move to the third study that we also published in Human Reproduction. And this study is very important because this study relates to the concept of low prognosis. So in this study, we compared the cumulative delivery rate after one aspirated cycle among Poseidon groups, and we used the control group of normal responder, I mean non-Poseidon patients, as the reference population. So the cumulative delivery rate per aspiration cycle was defined according to the ICMART definition. So this is, what is this? This is the number of deliveries with at least one live birth resulting from one aspiration IVF cycle, so expressed per 100 patients. For that, we need to include all cycles in which fresh and or frozen embryos were transferred, until one delivery with a live birth occurred or until our embryos were used. So in this study, we did exactly like that. And we used it for this study over 9,000 patients. So I want you to be with me because I want to show the survival plots that I'm presenting this slide. So it indicates that the cumulative delivery rate was significantly lower in all Poseidon groups compared to group 5. Group 5 in this slide is non-Poseidon patients, I mean patients with normal prognosis. So overall, the cumulative delivery rate in Poseidon patients were 33.7%, and it was 50.6% in non-Poseidon patients. So as I said, non-Poseidon patients are represented in this figure as group 5. But among Poseidon patients, this is very interesting, the young patient population, groups 1 and 3, performed significantly better than older patient population, groups 2 and 4. And in the logistic regression analysis, the number of oocytes retrieved and the availability of additional embryos for freezing and subsequent frozen embryo transfer modulated the cumulative delivery rates, as you can see in this slide. So a key finding of this study was that the cumulative delivery rates varied across Poseidon groups and were overall 50% lower than normal responders, substantiating the clinical validity of the Poseidon system for identifying and classifying low prognosis patients. But low prognosis related to an endpoint that is the cumulative delivery rate per initiated or aspirated IVF cycle. So this is what we consider this patient low prognosis. You need to use a fixed endpoint, and the endpoint is the cumulative delivery rate per initiated or aspirated IVF cycle. But it's important to note that the cumulative delivery rate varied according to age and also the number of oocytes retrieved. So group 4 had the worst performance as expected because this group comprised older patients with low ovarian reserve. Group 3 performed better than group 4, despite comprising patients also with low ovarian reserve because it included, younger patients. But what is quite interesting is that, sorry for that, I want to get back. What is quite interesting is that among patients of groups 1 and 2, and here you have group 2, here you have group 1, these patients, we split the patients in groups A and B. A, patients with less than 4 oocytes retrieved, and B, patients with 49 oocytes retrieved. And you see in both circumstances, group A, younger patients, the cumulative delivery rate was twice as higher in patients with between 49 oocytes compared with those below 4 oocytes. And the same trend was actually seen in group 2, patients older than 35 and older, So, the importance of oocyte number is stressed in also the Poseidon criteria, in which if we have the possibility of increasing oocyte number, we will be able to offer these patients higher cumulative delivery rate, which is understandable because we'll be able to have theoretically more embryos for freezing and subsequent frozen embryo transfer. Well, given the importance of oocyte number and female age for the cumulative delivery rate, the Poseidon group proposed a new marker of reproductive success in ART, namely the ability to retrieve the number of oocytes needed to obtain at least one euploid blastocyst for transfer in each patient. So this is the marker of success. And embryo euploidy was included in the Poseidon metric because implantation and live birth rates are relatively constant across all age groups after the transfer of euploid embryos. So it means that the availability of euploid embryos may help offset the adverse effect of female age on ART reproductive outcomes. So we have previous data confirming that the frequency of patients with at least one euploid embryos is higher in the younger patient population, which is not surprising. However, our data also shows that the higher the number of embryos obtained, the higher the frequency of women with at least one euploid embryo in all age groups. So one solution to improve reproductive success, particularly for patients with advanced maternal age, would be to have more embryos, because it increases the chances of that at least one of the embryos be euploid. But to have more embryos, we need more oocytes. And one question that we can ask is, how many oocytes do we need for each patient we treat? So for that, we have data, I mean, the studies of the ART calculator that I want to share with you. So we developed a predictive model that estimates the individualized probability of blastocyst euploidy per metaphase 2 oocyte as a function of female age and type of sperm used for IVF ICSI. So I mean, the ART calculator actually is a predictive model. There's no need to do PGTA to, provide the estimates. We only use that endpoint when developing the ART calculator, but the model can be used to estimate the number of metaphase 2 oocytes we need to theoretically achieve one euploid blastocyst. The variables that we included in the model were chosen because they were the most relevant ones impacting the probability of embryo euploidy based on logistic regression analysis. So using the model equation and mathematical functions, we created the ART calculator, which, as I said, is a clinical predictive model that estimates the minimum number of metaphase 2 oocytes needed to have at least one euploid blastocyst for transfer in couples with infertility undergoing ART. So the calculator, I will show you briefly here. Let's have a look at how the calculator works in practice. So pre-treatment, all we have to do is provide the patient's age and the type of sperm used for IVF ICSI. And then the user set the probability of success we want to have in our estimation. Can be 80%, 90%. Then with a single click, the calculator estimates the number of metaphase 2 oocytes needed to obtain at least one euploid blastocyst with the corresponding range, I mean the 95% confidence interval. Now suppose the predictive number of metaphase 2 oocytes is not achieved. In that case, the calculator can also be used to estimate the chance of having a euploid blastocyst with the number of metaphase 2 oocytes ultimately obtained. Let's say that initially the calculator estimated 12, but at the end of the day, you only got 6. And then you can also use the calculator to predict and discuss with your patient. For instance, what is the probability of having one euploid blastocyst in that embryo cohort? And this discussion is important. We feel in our clinic, the patients are happy to learn that, and also, consider having another cycle, additional stimulation cycle, specifically in case we are considering doing the dual stim protocol. So the ART calculator was externally validated using about 1,500 IVF ICSI patients from 3 fertility clinics in Italy, Genera Center in Italy by Filippo Baldi, also Turkey by the Center of Hakan Yarali that also helped us in the clinical validation studies, and also our center in Brazil. So we found in this validation study that the predictive value of the ART calculator was optimal, indicating that in real life settings, most patients who achieved the number of metaphase 2 oocytes predicted by the ART calculator actually got at least one euploid blastocyst in their embryo cohort when we checked the euploid using NGS. So the scientific validation of the ART calculator indicates that the application can be used in clinical practice for counseling and treatment planning. And I will show you briefly, shortly, the way we use in our clinic. Now I want to move to another interesting metric proposed by the Poseidon group, which is the follicle to oocyte index, FOI. So the FOI is computed as the ratio between the number of oocytes retrieved at oocyte pickup and the number of follicles at the beginning of stimulation. So we just make the ratio between the number of oocytes you get after oocyte pickup and the number of follicles you had at the beginning of stimulation and make the calculation. So the FOI is suggested to reflect the dynamic nature of follicular growth in response to exogenous gonadotropins. It may be particularly informative in patients with unexpected, suboptimal, or poor responses to ovarian stimulation. I mean, groups 1 and 2. Specifically, groups 1 and 2, because these patients, if you remember well, are the patients characterized by unexpected poor, less than 4, or suboptimal, between 4 and 9 oocytes retrieved, after using standard age and BMI matched doses of exogenous gonadotropins, despite having sufficient pre-stimulation ovarian parameters. So the low FOI values could indicate a hyper-response to gonadotropin stimulation, implying that only a fraction of available follicles was adequately recruited. As a result, only a limited number of oocytes is retrieved, and this phenomenon might relate to ovarian resistance to the gonadotropin regimen utilized. That could be related, for example, to specific genotype-based mechanisms involving polymorphisms of gonadotropins and their receptors. But other factors could be related to low FOIs, for instance, low gonadotropin starting dose, some environmental factors, asynchronous follicular development, and also technical issues involving triggering for final oocyte maturation and also oocyte pickup problems during, for instance, the aspiration pump, pressure, etc. We need to do an evaluation of the possible reasons why we have low FOI. But I think that in clinical practice, if you have low FOI values after one cycle, you should start the assessment of possible causative factors for this poor suboptimal response, and then analyze if the gonadotropin starting dose was too low, if you have the possibility of better synchronize your follicles, if there's any issues related to trigger or the oocyte pickup, and then try to adjust the stimulation protocol. So here is some interesting data of ongoing study by our team, including over 10,000 patients. So as you can see here, the lowest FOI values were noted in patients of groups 1, about 61%, the FOI values, and also group 2, 69%. So by contrast, patients of groups 3 and 4, as well as non-Poseidon patients, they have higher FOI values. I mean, again, groups 1 and 2 are the patients that in which the oocyte potential was not fully explored. Although we need more data about FOI in patients undergoing ovarian stimulation, I feel that strategies to improve the FOI and possibly overcoming the suboptimal response to stimulation could be considered. And strategies like increasing the FSH starting dose, use of LH supplementation, dual trigger could be considered for this patient population. Also here, I show you in this slide the percentage of patients with FOI values below 50%. Again, about 70% of the total population included in our study that comprised over 10,000 patients have FOI values below 50%. I mean, the follicular reserve was not adequately explored. And look at the prevalence in groups 1 and 2. It was quite high. Again, stressing the possibility of doing pharmacological adjustments in the ovarian stimulation. So now I want to focus on treatment strategies for these patients and how we do in our clinic. So basically, we follow a 3-step algorithm in which we, first of all, try to determine if the patient fits any of the 4 Poseidon groups or the 50 group of normal responders, I mean the non-Poseidon group. Then we use the ART calculator to estimate the number of oocytes we need to optimize success. And finally, we design individualized treatment plan to help us achieve as much as possible the estimated oocyte number. And obviously, we discuss the treatment with the patient on a shared decision basis. Just to give you an example on how this works in practice, let's consider a case of one patient who came to seek treatment with us with a history of 2 previous failed IVF cycles and poor ovarian reserve. So this patient shown here is kind of infertility duration of 3 years, tubal factor, AFC of 4. The male partner had idiopathic oligosteroteratospermia, 2 stimulations before in different centers, 1 using mild stimulation protocol, only 2 oocytes retrieved. Although embryos were transferred, no pregnancy was obtained. And the second cycle was kind of short protocol using HMG with 2 to 5 international units per day, but unfortunately no eggs retrieved. So these patients, if you put the patient under the Poseidon classification, the patient will fit group 3 because she's young, but the ovarian markers are low. And also the number of oocytes retrieved in previous cycles were quite low. And if you kind of use the ART calculator, including the patient age and the sperm, ejaculated sperm that we plan to use for ICSI, you find out that the ART calculator estimated 5 metaphase 2 oocytes, the 95% confidence interval between 4 and 6 to obtain at least 1 euploid blastocyst for transfer. And then we go for step 3, in which the treatment primarily take into consideration the ovarian reserve, which was very low. So in a case like that, we opt to use the dual stim protocol. This was what we did in this patient. We did dual stimulation, and at the end of the day, we got 6 metaphase 2 oocytes, and we got 3 blastocysts vitrified. And this is just an example of a case using the concept of the Poseidon classification, the ART calculator, and then guiding the treatment based on the number of oocytes needed to obtain at least 1 euploid blastocyst. So the Poseidon stratification has helped us to manage our patient more efficiently. So the dual stim is one of the treatment options, but there are many other possibilities. There's a collection of articles published in Frontiers in Endocrinology, several of which deal specifically with treatment options for Poseidon patients. These articles are free to download, so I invite you to check the collection of articles published in Frontiers in Endocrinology as shown in this slide, these open access articles. But one thing to bear in mind is that patients of groups 1 and 2 may benefit, as I said before, from adjustments in the ovarian stimulation protocol to have more oocytes collected and therefore more embryos. And the reason is these patients are characterized by having adequate ovarian markers. So we have now several studies published recently exploring pharmacological interventions for Poseidon patients of groups 1 and 2. So the most exciting data that I found in the literature include the studies exploring increased recombinant FSH doses, refinements in the use of GnRH analogs, I mean the antagonist protocol, and also the dual stim protocol for these patients. We need more data, but what we have at the moment is that adjustments in the ovarian stimulation protocols seems to be of clinical utility to patients of groups 1 and 2. Now, if you think about patients of groups 3 and 4, these patients have poor ovarian reserve. But in these cases, treatment should be planned, keep in mind that the number of oocytes needed to achieve at least 1 euploid blastocyst will be lower in young compared to other patient groups. So also in this area, the number of studies exploring treatment options in groups 3 and 4 has increased steadily. We have many papers published recently exploring different interventions like the dual sting protocols and other ways to improve oocyte embryo quality. So the most exciting data so far comes from studies showing a potential benefit, for instance, of coenzyme Q10 in group 3, DAGA in group 4, refining the use of GnRH antagonists, and also progestin primed ovarian stimulation, dual trigger, and LH activity supplementation. But the list of included studies is quite large. We certainly need much more data, particularly from large-scale studies and randomized controlled trials, but I feel that the enthusiasm raised so far by several groups of investigators demonstrates a genuine interest for advancing the knowledge in this area. So in our clinic, basically, we do like this. This is like a snapshot of the treatment options we use at Androfert. So basically, the antagonist protocol and recombinant FSH are the backbones of our stimulation strategy for most Poseidon patients. The LH supplementation is added to patients of 35 years and older, I mean groups 2 and 4, and the dual trigger is frequently used in groups 1 and 2 to improve, FOI. Dual stim is commonly used in patients of groups 3 and 4, and PGTA in patients of advanced maternal age. And then, on a case-to-case basis, adjuvants like growth hormone, DAGA, minimal stimulation with embryo pooling, and oocyte donation are considered. So that brings us to the end. And I want to wrap up my talk with a few take-home messages. The first message is that the Poseidon criteria underline differences in prognosis of patients undergoing ART based on oocyte quantity and quality, possibly creating more homogeneous groups for clinical management and research. And secondly, the clinical utility of the Poseidon stratification has been validated by real-world data. We have data showing that Poseidon patients are very common in clinical practice, that either AFC or AMH can be used for patient classification, and the thresholds as proposed by the Poseidon group provide acceptable and equivalent accuracy in predicting poor oocyte yield, and that Poseidon patients have indeed low prognosis compared to non-Poseidon patients. But remember that the prognosis in terms of cumulative delivery rates per initiated or aspirated IVF cycle vary according to Poseidon group, primarily due to age and number of oocytes retrieved. Another point is that the ART calculator might be considered for estimating the Poseidon metric of success in ART, and the results obtained by the ART calculator might be used to set patients' expectations and help guide treatment choices. It emphasizes how age, aneuploidy rate, and oocyte number are important factors for ART success. And about treatment, an individualized treatment plan may be proposed for each Poseidon group. In patients of groups 1 and 2, treatment is primarily focused on pharmacological interventions to optimize ovarian response and increase oocyte number and quality. And in patients of groups 3 and 4, treatment should be focused on ways to enhance oocyte embryo quality or increase oocyte embryo number through accumulation strategies. But in all cases, it is crucial to keep in mind that the number of oocytes needed to activate at least one euploid embryo for transfer differs between young and older patients. And as I said before, although we need more evidence in this area, the patient-oriented strategy encompassing individualized oocyte number for each Poseidon group may improve success rates and reduce time to live birth, ultimately improving care and contributing to total quality management. So thank you very much for attending this webinar. It was a pleasure participating, and I will be available for answering any questions that you might have. Thank you very much.
Thank you, Professor. I think it was a terrific summary of the journey of Poseidon from ideation in 2014, 2015 to real world application now. And in India also now we are waking up to the application of Poseidon in our daily practice. And I'm sure that we have august audience today, and they would be bubbling with their questions and queries as to how to apply this essentially stratification theory to our daily practice. So I think it was a wonderful talk, and I open the house for my colleagues today to come back and ask questions. Let us first try and do questions on the talk that Professor gave today. So Poseidon and COS related questions invited first. The house is open. Anybody can raise his hand and start asking questions. House rules are very simple. You will raise your hands and ask questions once I come back to you, and rest of you are requested to keep yourself on mute. Please go ahead. We can ask questions. You can use the chat box option also, in which case I will read out the question. So I do have one question. I'll start with that question. That's from Dr. Jayashree Sridhar. She mentions, let me congratulate you on your excellent deliberation. All along, we have used estrogen priming prior to COS, but you said progesterone pre-supplementation. So would you please explain PPOS?
Okay, thank you very much for actually starting the discussion. The protocol that we use is using actually norethistérone. So we do cycle programming. So in the previous cycle, I mean the cycle before the ovarian stimulation, we start norethistérone daily from cycle day 21. We use the norethistérone 5 milligrams twice daily. So here in Brazil, we only have the 10 milligram pill. So we split the pill in two, give 5 milligram in the morning, 5 milligram in the evening. It's important to split and give it twice daily because of the half-life. And then we can synchronize the follicular cohort beautifully. Actually, when you give the last pill, so we give the last pill in the morning, let's say 5 milligram, I would say 99% of cases, the menses will come 3 days later. And then we start the antagonist protocol. So you can use the estrogen priming as well, specifically if you have anovulatory patients, because the norethistérone is good for ovulatory patients. And the estradiol priming, as several people use, is quite good for anovulatory patients. That is good as well for cycle synchronization. But if you have ovulatory patients, I think for us, it's quite interesting, this norethistérone protocol. We published results on that. And in terms of quality management, is fantastic, because actually, in most cases, the day of oocyte pickup. So we can distribute in the clinic, evenly, the oocyte pickups across the week. So we don't have, let's say, too many cases in one day, too little cases in the other day, which is sometimes quite challenging for the laboratory, specifically when you have difficult cases like severe male factor infertility with sperm retrieval, which is quite common for us. So we can actually plan our cycle better using this protocol. This is one protocol not actually proposed by us. It was proposed many, many years ago, and in France, it started in France, and then it was a kind of taken further by the group, the German group of Professor Robert Fischer in Germany, in Hamburg, and then basically actually we followed that particular thresholds. So basically, this is the protocol.
I'll extend this conversation a little more just for clarity of my fellow panelists and participants. There is a follow-up question on this, that if you would want to give norethistérone 5 milligram twice daily, how long can you continue this for programming your cycles? And B, does the high progesterone at the start of the cycle impact your implantation rates? So these are the two questions on this.
Yeah, I mean, the norethistone protocol is interesting to postpone the cycle. I mean, you can give a minimum of 8 days, not less than that. We give 10 days, but you can give 9 days, 11 days, 12, up to 14 days. So I mean, if you are traveling and you don't want the oocyte pickup to actually be on that particular day, or your operating theater will be very busy in that particular you want to distribute, you can postpone the cycle 1 day, 2 days, 3 days, 4 days. So between 8 and 14 days, you are in the safe, let's say, range for using the norethistone protocol. So not good for advancing the cycle, but it's good for postponing the cycle for a few days. This is one point. So the progesterone is not an issue. If you kind of measure progesterone in the beginning of the cycle, you see that the progesterone will be low. There's no issue actually in terms of having high progesterone by giving norethistone. Obviously, it's important to have the washout day period of, I mean, having the menses and then starting the stimulation 3 days later or even 2 days later, but we don't feel a problem on that.
And does it impact the implantation rates in case we are doing a fresh transfer?
No problem. I mean, we use fresh transfers for these patients. And we are not actually observing any detrimental effect. So for the norethistone protocol, the lessons we learned was that we feel we need to provide supplementation with LH activity. It's important. So in every single cycle that we use the norethistone protocol, we are keen to provide some, LH supplementation. If the patient is 35 and older, just start the supplementation day 1. The protocol using LH activity from day 1. In our case, we use recombinant LH combined with the recombinant FSH. Like we use the Pergoveris formulation, which is available in our market. But you can also use, explore different options. But if the patient is young and you consider that FSH alone will be enough, just kind of look into the follicular development. And if you feel day 5, day 6, when you are about to give the antagonist, that the follicles are not growing the way you like, just add the LH supplementation day 6. So, for the norethistone protocol, this is basically what I can tell you. You can do fresh transfers, you can do freeze-all. So, it will be something that the doctors and the embryologists will appreciate, especially in busy clinics.
And how do you compare that with the estrogen priming? Do you see any distinct advantages for this?
I think that, we have little experience with estrogen priming. Based on the literature, I can mention to you that it seems quite decent, and that should be similar results. I don't think that we will have big differences. The only thing is that, the norethistone is valid for ovulatory patients, and the estradiol will be okay for all patients, I would say. But the other thing is that, we can, it's easy to kind of control, because one good thing about the norethistone is that when you give the last 5 milligrams in the morning, well, you can, as I said, in the vast majority of cases, know the day of menses. This is very interesting because you know the day you're starting the stimulation. For instance, our protocol in most cases include 2-to-1 ratio of recombinant FSH and recombinant LH, and we give 300 international units per day of recombinant FSH, 150 of recombinant LH, the Pergoveris formulation. And these patients, I would say, the vast majority will respond under 10 days stimulation. So, for quality management purpose, is quite interesting. But the question of comparison, we don't have direct comparison between estradiol priming and norethistone priming. I feel both are good. Our experience has accumulated much more using the norethistone over the recent years.
Thank you. Questions are flowing in fast and furious, and keep them coming. We are lucky and we are honored to have Dr. Asha Rao with us. She is one of the pioneers of ART in India. And I open the house. She can ask her question directly to Sandro.
Thank you, Dr. Gutkutia. I'm enjoying this session. And Professor Sandro, it's very nice to listen to you. You have been to our center twice at Coimbatore. And I have put my question there. This is a lady who is group 2. She's 40 years with AMH of 4. And she had stimulation with recombinant FSH 225 plus recombinant LH 75 for 11 days. And she had 9 follicles. 5 were more than 1.7 and 4 were more than 1.5, and 225, 2 ampules recombinant HCG trigger, and we got only 1 oocyte.
So group 2, how do you classify this as a group 2, madam? Her AMH was 4 and AFC was 17. The age was 40.
8 plus 9. One
Okay.
already had 8 and one already
Perfect.
had 9. Yeah.
So, Professor, please.
40 years. 40
40.
years.
Yeah.
40 years and 6
So
months.
First of all, it's very nice to see you, Dr. Rao. I enjoyed very much the experience I had visiting our center twice. I vividly remember being with you for a few days. Thank you very much for having me
Thank you
and
so
also
much for
participating
remembering.
today. So yeah, I mean, this patient's group is group 2 because she's older than 35. She has got decent, normal, sufficient ovarian reserve markers, and then at the end of the day, it was, I mean, a disaster in terms of oocyte number. She was kind of group B because less than 4 oocytes. Well,
Yes.
very complicated case because, I mean, you are experienced in the ovarian stimulation, no doubt about that. So there's no issue related to low gonadotropin starting dose. As we can see, you kind of provided LH for this patient. And I mean, if you go, this is low FOI for sure, because if you consider 1 divided by 17, the FOI, follicle to oocyte index, 1 divided by 17 is going to be very, very low. So what we can do? Well, first of all, check gonadotropin starting dose, which is good. Second, if you feel that the cycle was synchronized, I mean, if it was not completely synchronized, you might consider giving some cycle programming, as we discussed it before, using noretisterone or estradiol priming. You obviously need to check if any problem occurred during trigger, but you gave her 2 vials of HCG. Pretty good. So let's consider no problems during the aspiration, no problems with the aspiration pump. So most probably this patient has genetic issues, I feel. And she's not obese, correct?
Her BMI is 28.
28, so she's not obese. So there's no issue related to BMI. So the only thing is that perhaps in this patient, if we consider theoretically that she might have polymorphisms affecting, I mean, FSH or LH, the only thing you need to consider for the next cycle, and perhaps you have done that already, was to increase dose. And then perhaps consider increasing the dose both. I mean, we prefer the 2-to-1 ratio. I know that you have used it, like say the 3-to-1 ratio of FSH and LH. We use the 2-to-1, but I mean, I would consider for next cycle increasing the FSH dose and also the LH dose. Most probably in that case, we would go for 300 FSH and then 150 LH. And most probably I would try the dual trigger I mean, giving triptorelin, perhaps 3 vials, 3 syringes, and then Ovitrel, if you have that available, another ampoule, dual triggers. So perhaps that will be my, it's easy to comment on a case like that after it
how
happened.
many ampules of triptorelin, how many ampules would you give?
I would give 3 in that particular case, 3 ampoules.
Okay, okay.
Yeah.
Yeah,
And then
because
Ovitrel or HCG, recombinant HCG, which is our trigger protocol using recombinant HCG always.
because she had the previous cycle, which was Gonalef 225 plus Menopure 150 earlier she had, and then also she had 1 oocyte. So our center, we gave her Luvaris. Perhaps we could give her 3 ampules of
because the other question in this, because this is interesting case, we are talking about FOI, follicle to oocyte index, but another thing is kind of, as you mentioned, the follicular development was okay because she got adequate number of growing follicles.
Yes.
Right?
There was synchronous, yes.
Yeah, because there are two things here to consider. One thing is, if you get, let's say, very low follicular development,
because her estradiol was 1,500, which is less compared to the number of oocytes that she has, I thought.
Sorry.
1,500 estradiol.
Okay. Yeah, 1,000. Yeah, this is consistent with the definition of hyperresponder. I mean, you get low estradiol levels, but I mean, there are 2 different ways to look into the problem. One way is to look into the follicular growth that you see during your stimulation. If you feel that the follicular growth is kind of a bit slow, then you should think about FSH polymorphisms. And then increasing the FSH dose makes a lot of sense. If you feel that the follicles are growing kind of steadily, and then you end up having things like that, it might be related to LH polymorphisms. And then the supplementation makes a lot of sense. But I mean, we cannot trial and error in a case like that. It's complicated. Ideally, we should have pharmacogenomic approach, which is not available to most of us on a routine basis. Obviously, if you have a panel in which you can check the most common FSH receptor polymorphisms and LH beta, I mean the molecule polymorphisms for LH, then you can also perhaps say, okay, this patient has a combination of polymorphisms or has only FSH or only LH, and then you tailor the protocol accordingly. In practical ways, what we need to do is actually attack on both sides, increasing the FSH dose. Then you can consider going to 300 and even 375. And then providing LH supplementation. Providing LH supplementation, in my mind, is using recombinant LH because we are providing the molecule itself. And if you have LH beta polymorphisms, and then providing the proper molecule will be much better than providing LH activity, in my opinion, using HCG, like let's say HMG. But if you have a receptor, LH receptor problem, then still you might have condition in which the number of oocytes retrieved might be suboptimal. I mean, because we can have a problem in the receptor or in the molecule. So, I mean, the receptor are more often seen with FSH, and increasing the dose we can overcome. But with LH, if the problem is related to the molecule going to the receptor, it's increasing the dose makes sense. If the problem is in the receptor, you might have more difficulties. Still, the only way is actually providing what is defective or missing, and then This is what we have at the moment for patients like that. And also the trigger, consider actually using the dual trigger, because the dual trigger, what's the benefit? It will be the FSH surge, because when you give the GnRH analog, triptorelin or any other molecule, what we will have is like providing the patient what we see in the natural cycle when actually we have the LH surge is actually you have
And what
also.
exact, sorry, if I can.
Sorry?
Dr. Rao had a comment.
What exactly is the dosage of your dual trigger?
The dual trigger, in routine, we give 2 ampoules of triptorelin and 250 micrograms of recombinant HCG. So we give 1, we have the Ovitrel pen, we give 1, and we give triptorelin 0.2 for the patient, for the trigger.
Okay, thank you.
Dr. Rao,
And in one of your slides, Pergovaris 2 ampoules.
Yeah, because
so Pergovaris 2 ampoules means FSH 600 plus LH 300.
no, actually, if you give, I believe, because now in our market, we have the Pergovaris pen, in which we can use like the Gonalef, so we can adjust with the dial. But I think the ampoule that you might have, and perhaps Dr. Bharat can correct us, but I believe you have ampoule which has 150 FSH and 75 LH, 1 ampoule. So if you give 2 ampoules per day, then you give 300 FSH and 150 LH. Then you make the ratio 2:1, which is the protocol that we use in our center.
Okay, thank you. Thank you so much.
Dr. Rao, in case you do follow up on this patient, please keep us updated, because
Sure.
we'd like to see what the effect had. Dr. Jayashree also had a follow-up on question on this as to why were you recommending a dual trigger for this patient? So you've already explained that. Thank you. And she had another question as to, in certain kinds of poor responders, especially endometriotic patients on long protocol, they tend to go long. They require stim for 13, 14 days. Is it okay to stim them? Or do you think that there is a particular time by which your stimulation should be over?
Yeah, okay. This is important question. I think that for the long protocol might work for certain patient population. Although most of us, I believe, we are now into the antagonist protocol, there's still some patients that could benefit for the long protocol. For us, the long protocol means always giving a patient like that is giving a protocol using FSH and LH. So LH supplementation is there. I believe that, the longer the stimulation, the worse the results we get. So, and we prefer to freeze all in case like that. So we kind of, if the stimulation goes above 13 days, for us is like looking into the lab what we get and freezing all, and then preparing the cycle subsequently. So we prefer not to transfer fresh in case we have long stimulations.
Fair enough. Thank you. She has another follow-up question about adjuvants. I'll take that a little later. I would come to Dr. Rita Bakshi. She is another key opinion makers in this country. And Dr. Bakshi, if you don't mind and switch on and ask your question, we'd be very happy. Dr. Bakshi, can you switch on the mic and ask your question, please? Okay, I don't see much activities. I'll ask her question for you. She asks us, in poor responders, do you see any role for the growth hormone? If yes, then how? If not, then what?
Hello.
Well,
sorry.
I think the literature...
Yeah, she's there. She's there. Sorry,
I'm
Dr.
sorry.
Bakshi. Yeah.
It took me a little bit of time trying
please.
to put this on.
Welcome, Dr. Bakshi. Please go ahead and ask your question.
Thank you so much. Yeah, so what I wanted to know was, we've been using growth hormone here quite a lot. And I was really wanting to know whether you find it effective enough in your side of practice.
So before I put the question to Professor, what's your experience been like with the growth hormone?
We have been using growth hormone in selected cases, specifically patients in groups 3 and 4. I mean, not routinely. I mean, the first cycle, we try to, stimulate the patient with protocol based on recombinant FSH and recombinant LH, the way I presented to you before. I mean, using recombinant LH in patients older than 35, and then recombinant FSH monotherapy in higher dose in patients of groups 3, I mean, younger. But obviously, the growth hormone has been explored by some groups. I think the data is promising. There's a lot of rationale in the pathophysiology of these patients that growth hormone could potentially help, but we still need more data in terms of specifically these Poseidon patients, the role of growth hormone. We have some data, retrospective studies showing benefit in group 4. And I feel that specifically, if I have a patient between 35 and 40, these are the patients that I feel we should explore the growth hormones. Because I mean, if the patient is over 40, I mean, whatever we do, we have the problem of embryo aneuploidy. And our results will be confounded so heavily by the high aneuploidy rate that it's very difficult to kind of compare and assess our data properly. For instance, what I want to say is that it's very important that we look into our data splitting. Even when we say that the Poseidon patients, we have groups 2 and 4, I mean, they are all 35 and older. Well, I personally feel that we have 2 different groups in there. We have patients between 35 and maximum 40, and then we have over that, because I mean, we see that the results are different. So I feel my opinion is that every single pharmacological intervention using adjuvants, DHEA or growth hormone might be better fitted to patients up to 40 years old. Because what is the purpose of giving growth hormone if the aneuploidy rate is so high? We won't be able to change anything in the genetic aspects, but the cytoplasmic aspect, the energy booster that the growth hormone could provide, could be actually beneficial to patients with still aneuploidy rates not so high. So this is my insights on the growth hormone, and I feel it's okay to try and observe. Well, now we are more like going into the dual stim protocol more and more, because when we, sit with the patient, enter the data into the ART calculator, and the patients are sometimes very disappointed, especially the older patient groups, that we need so many oocytes, theoretically, to have one aneuploid blastocyst. And then we kind of, what we can offer, obviously, if you give the growth hormone, you might increase the oocyte yield in 1 to 2. This is the average, let's say, based on the literature. Perhaps your experience is even better, and I would like to hear from you. But when we look into the studies comparing group using growth hormone versus not using the growth hormone, we see average oocyte number difference is about 1.2, 1.5. So I can provide that to my patient, but obviously we are also looking to the cytoplasmic energy booster that the growth hormone could provide, which is important for cytoplasmic maturation and embryo quality. Fine. But still, you have the problem of aneuploidy. And the older the patient, the higher the aneuploidy rate. So we are also discussing with the patient having more than one stimulation, and preferentially in the same cycle, because we make package for these patients. That will be financially more attractive because we make it some savings for the patient if the patient undergoes 2 stimulations in the same cycle.
Ma'am, what's your experience of using growth hormone, and what is the dose that you give, and when do you start?
So I am using 4 IU from day 2 onwards, and we continue till day 10. And I agree with Dr. Sandhu that we get around 1 or 1.2 number of eggs more. But I think as long as we have a better clinical pregnancy rate, and that's what I have observed, I find it quite effective. So we use it very frequently, and soon we'll be publishing our data on use of growth hormone in poor responders.
Excellent. Thank you. And please
Excellent.
stay on.
Thank you for sure.
And please make your comments. I am sorry, I'm not able to identify this person. Goes by the name of ECT iPad 03. And the question that is posed is, recently I've heard that adding letrozole 5 milligram from day 1 of stimulation till trigger is showing good response and increased clinical pregnancy rates in POR patients. What is your experience on it?
Well, I mean, I feel that the minimal stimulation protocol using letrozole is something that you might consider. Also, some doctors using clomiphene citrate with the minimal stimulation. I mean, the poor responder patient, we have many different ways to approach. In cases in which because our first line therapy is like I showed you before, so we kind of leave the letrozole stimulation protocol for patients not willing to go for oocyte donation. Let's say we fail the first, second cycles, and we also discuss with the patient the dual stim protocol. This is our approach. And if we fail on that, we might consider different alternatives that could be related, even using dual stim, using letrozole. This is valid, I feel, specifically if the patient wants to pursue, on eggs. I think then you can do oocyte or embryo pooling. We prefer embryo pooling, but I feel that this is something that you might consider giving letrozole, yes. But look into the FSH levels, because I feel that if you have very high FSH levels from a poor responder patient, that might be more challenging actually to stimulate using anything, including letrozole or clomiphene citrate.
Thank you. We have, so we're basically looking at 2 distinct groups of questions now, one on duostim and the other one on LH. I'll take the LH questions first. Dr. Sangeeta Sharma, would you care to come on live and ask your question yourself? Dr. Sangeeta Sharma, will you requesting? Yeah, please go ahead.
Good evening, everyone. It was a wonderful talk, Dr. Sandhu. And my question is that based on the different categories of Poseidon which you've mentioned, how do you decide where to supplement the LH from the very beginning of the stimulation and where to add on, as you said, after seeing the stagnation of the follicles? So how do you decide that? Is it on the basis of the Poseidon group or on the serum LH levels or anything else?
Before you answer the question, Doctor, there's a follow-on question on the same topic from Dr. Neha, who is our international colleague from Nepal. And she asks, how do you think LH is better than an HMG? Can you combine both the questions and answer them?
Okay. So thank you very much for bringing the topic on LH. And also when we add LH during the cycle. So my take is like this. So for the Poseidon patients of groups 2 and 4, I'm talking about older patients. I'm talking about patients 35 and older. For me, I always give supplementation, LH supplementation from day 1, stimulation. So I don't wait to observe any stagnation, nothing, because we have data and we published a study, a meta-analysis, systematic review and meta-analysis in reproductive biology and endocrinology last year, looking to, the hyper-responder patient population, fitting like groups 1 and 2. And we got, evidence suggesting that specifically for patients 35 and older, we have the beneficial effect of giving LH supplementation from stimulation day 1. Now, these are groups 2 and 4. Now you have groups 1 and 3. These are younger patient population. So then group 3, you don't need a previous stimulation to decide the patient's group 3, because this patient is like, for example, 33 years old and poor ovarian reserve for any reason. For that particular patient, the reason of poor ovarian reserve can be many, including genetic problems. Well, if you start your stimulation with FSH monotherapy in a proper dose, and you feel that although the patient has poor ovarian reserve, still that low number of follicles are not developing, well, I will add LH activity when I start my first antagonist injection. So this is like in the mid of the cycle. And the same goes for group 1. Group 1, I have that patient in which if you don't have a previous stimulation, you will start with the hope of the patient will perform as a normal responder, because consider a patient younger than 35 with adequate ovarian markers. So in most cases, the patient without previous cycle, we are keen to start with dose of FSH around 2 to 5. Monotherapy in most cases. And then we go and have, let's say, a suboptimal 4 to 9 or poor below 4 oocytes retrieved. And then we need to plan the second cycle. Well, if I had that experience and I feel that the low FOI that I got was unrelated to any trigger issues, aspiration technical issues, if my dose was adequate in terms of FSH in the first cycle, I will add LH supplementation from the beginning, from stimulation day 1 in my subsequent cycle. So if I feel I started with FSH dose too low because I was afraid of OHSS, I started with 150. And then in that case, I might consider planning the cycle again using FSH monotherapy. I start with 300 international units per day because I'm thinking of FSH receptor polymorphism. And then I increase my FSH dose 300. And they start my stimulation. This is the antagonist protocol. I'm planning to give the dual trigger. And then in the mid of the cycle, I feel that it's not going well as expected. The follicles are not growing the way I like. Their kind of stradiol levels are not climbing up. And then, well, I think it's fair to add LH in the mid-cycle onwards. And then I will add 150. This is my protocol, recombinant LH per day. So I think we need to individualize, but just to give you my perspective on how to kind of use the Poseidon stratification still to decide, okay, this is 35 and older, go for LH supplementation from day 1. But in other categories, we need to kind of have some room for flexibility and then decide if we keep with the FSH monotherapy in patients who had low starting dose in previous cycles, or if you would like to start from day 1 stimulation with the combination. And then we go for the question related to, if I may, related to, the differences between
recombinant
HMG
LH,
and recombinant LH. Well, the question is kind of explored by many studies, and also pharmacological studies showing the difference between the molecule. Because the short answer is that when you give recombinant LH, this is the molecule that the patient has that is important for folliculogenesis. We need both molecules, FSH and LH. They need to work in synchrony. We don't know exactly how much LH is needed, but we need a minimum threshold. It's not so good to look into the LH levels because the analytical assays are not good to detecting low LH levels, although some authors have explored trying to find LH thresholds below 1 after, let's say, you start your stimulation, you give your antagonist, and then you check LH. Well, this is not according to what has been proposed by even the ASHRAE guidelines on ovarian stimulation, because I mean, there's technical issues related to the analytical method, so it's not very helpful. So looking to LH might not be the answer. I feel that we need threshold of LH. When you give supplementation with LH, in my opinion, it should be more than less. I mean, I like 150 as the LH supplementation. When you give HMG, you are also giving LH activity, but you are not giving LH, because obviously in HMG, we don't have these recombinant molecules inside the vial with exact amount of FSH and LH. HMG is purified from the urine of menopausal women. And the urine of menopausal women does not have this 2-to-1 threshold. It's impossible. So what they do, they add LH activity. How? Giving the cheapest molecule available, which is HCG. So HCG, you know, also goes to the receptor, LH receptor. Both HCG and LH have the same target, which is the LH receptor. So when you give HMG, the LH activity provided by HCG goes to the HCG, the LH receptor, like a recombinant LH. But the problem is not the receptor, is what happens afterwards. It's intracellular pathways are completely different. And this we have nice studies using in vitro granulosa cells, showing also, because the granulosa cells are the target for the receptor, for the LH and HCG, and you see that the pathways are completely different. So the pathways related to recombinant LH are more kind of growth factors, while the HCG pathways are more apoptotic receptors, because HCG molecule also might provide downregulation of the receptors, because the half-life, remember, of HCG is 5 to 7 days. So when you give stimulation in a patient using LH activity, you might actually decrease the number of LH receptors, because you kind of stick the receptors with HCG that will be there for 5 to 7 days, and then next day you give another dose, another dose, another dose. So this is the principle of downregulation. Well, if the patient is a fantastic responder with many follicles, you won't be able to see that detrimental effect. But we are talking about low prognosis patients here. And then we don't want to do that. We need to keep the receptors alive and also the intracellular pathways alive. And then this is why the data supporting recombinant LH is more kind of convincing, because of these intracellular pathways and the possibility to avoid these downregulations that might happen when you kind of give HCG LH activity using HMG.
On a personal note, I heard you talk about using LH in your practice around 7-8 years back when you came around to India national conferences. And now today I've heard you talk about Pergoveris quite a few times. So have you graduated from Luveris to Pergoveris, or you still use both Luveris and Pergoveris? And what's your experience with Pergoveris now that you've been using it for some time?
Thank you. Well, I think it's more like market issues, because I mean, the molecule, the Pergoveris is kind of putting Gonalef and Luveris together to make it easier for the patient to have just one injection. So what the company has done is basically trying to make the treatment more patient-friendly. But the molecules are the same. I feel that if you give recombinant FSH using Gonalef 300, and then 150 Luveris is actually the Pergoveris that you are giving the patient. For us, in our market, actually, the company has kind of replaced the Luveris using by Pergoveris. This is why for us it's quite the experience that we have got. I was using before, as you mentioned, the Luveris formulation because I mean it was the way to supplement with recombinant LH. But now we have this formulation coming together. The patient actually appreciate having a pen because in our market, in our culture, the patients will not come to the clinic to have the injection. They will do at home. This is kind of self-administration. This is Brazilian culture. They will not come to the clinic. Okay. They want to do it at home. And now with this COVID area in which the telemedicine was spreading around, patients are even more, I mean, keen not to come to the clinic, only if needed. So, I mean, I now use Pergoveris because of convenience. The company is providing the combination in the pen device. This is basically, but the molecules are the same.
Thank you. I'll have a couple of questions on adjuvants or add-ons. So there is one question by Dr. Jayashree Sridhar. I would be happy if she comes on live. She asks us whether adding resveratrol helps to improve egg quality. If yes, then in which kind of patients?
Well, for that particular one, I don't have experience. I mean, I won't be able to comment on that. Perhaps any other participant would like to say that. So we are not using actually. I know the studies actually discussing resveratrol in many issues. I mean, not only that, also in sperm quality, there's antioxidants in there. The molecule actually is rich in antioxidants, but I'm not sure. I mean, theoretically, giving antioxidants, if it's balanced, redox is a problem for male infertility patients, for poor ovarian responders, and giving antioxidants seems to make sense, but we don't know actually the dose, the formulation that would benefit our patients better. So each of us, I believe, if we discuss antioxidants, we will come up with certain formulations that we prefer because we don't have a consensus.
Dr. Sridhar, would you want to make a comment?
Yeah, I got what he said, but like, you know, we were using it in some PCOS patients along with metformin pre-stimulation and thought we got a good result. So maybe Asha Rao ma'am would like to comment whether she has been using.
No, I have not used that, Jayashree.
Okay.
No experience.
Fair enough. And Dr. Sangeeta Sharma has another question on the same on a similar topic. What's your opinion of use of DHA? In one of the slides, you did mention using DHA as one of the add-ons in 40 plus group and testosterone gel. Which specific group, how long, and observationally does it help?
Yeah, I mean, we have some data on Poseidon patients specifically about DHA. Groups using 75 milligrams pre-stimulation, I mean, for 2 to 3 months pre-stimulation in groups 3 and 4, DHA, and also testosterone. This has been explored. So results are, I mean, seems promising in patients up to 40 years old, but based on retrospective data. We still need, I mean, RCT to see if these drugs, adjuvants, might help in randomized control trial. I mean, obviously, observational data provide some hope for groups 3 and 4. I mean, these are the low ovarian reserve patients. And I feel that it's valid to try in the clinical practice, especially if, I mean, you have patients up to 40. I mean, older than 40, I'm more into the dual stim protocol. We need to have more embryos, more eggs, more embryos. But for patients of group 3, in which they are young, I feel that, I mean, the aneuploidy is not a big issue. And anything that you can do to improve, I mean, fertilization rates and embryo development, or increasing 1 egg, 1.5 egg, I mean, in the average, let's say, comparison groups might help. But still, these are based on retrospective data. We don't have, let's say, consensus on use of adjuvants so far for Poseidon patients.
I just have one concern about DHEA, that most of the early papers were from a closed group. So somehow we have not gotten around to do some solid RCTs on this molecule. Sujata ma'am has raised her hand. Please go ahead. She also has posted a question. Is this the same question that you're going to ask? So please go ahead.
Yeah. Actually, with the usage of Pergoveris, I have noticed when we have used that, there is a severe headache which has been encountered by the patient on day 7. Hope I'm audible.
Yeah, please.
So,
we can hear you.
So, is there any side effects or anything of this is related to the stimulation, or is it anything unrelated? Have you had any of such experiences? Because once I changed the drug, so these couple were like low variant reserve patient, Poseidon group 3 patients whom we started on Pergoveris 300 with growth hormone of 6 units, and after 6 days and 7 days of stimulation, there was no response. He started complaining of severe headache, and then I changed it to a human menopausal gonadotropin, highly purified, and she was comfortable after that, and she did get a good number of oocytes after that. So, is it anyway related to it? Is what is I wanted to
I
ask.
have been using Pergoveris, and I don't recollect any such patients complaining. Professor, what's your comment?
The same as yours. I mean, we use quite a lot. I mean, we don't have this complaint. Perhaps a kind of individual case, the patient might have got other issues. I'm not sure about the growth hormone either. I mean, we have used growth hormone in several cases, and I don't recall, I mean, patients complaining of headache. Could be one or other cases unrelated to the stimulation, and just by chance, when you change, the patient actually got better. But I don't actually think that the molecules are there. I mean, these molecules are in the natural cycle as well. We are giving recombinant. Recombinant is very pure molecule, like nature. So I feel that perhaps this patient have got something else.
Yeah.
Dr.
Because the nitrogen levels were also not very high. It was around 400 when I stopped the drug. Yep. Thank you.
Yeah, those.
Dr. Sridhar, Pergoveris is actually available in India. The next set of questions, and possibly the last set of questions, we've been holding Professor Sandro for more than an hour and a half now, are all to do with DuoStim. I invite my colleague Oendri to come on live and ask her question. Is she comfortable doing that? Dr. Oendri, please. No action. Okay, then I'll go ahead and ask her question. Is there any difference between doing DuoStim particularly versus 2 to 3 back-to-back stim cycles in the group 4? And do you think the luteal part of the luteal phase stimulation has some special role or a special application?
This is the very interesting and challenging question, I think, because I mean, the rationale of doing DuoStim, I believe there are 2 rationale on that we need to discuss a little bit. The first one is actually you are kind of priming the follicles in the first stimulation with gonadotropins, and then in the another wave, because in each cycle the patient might have even 3 waves of follicles. It has been shown, multiple waves, and I mean, the waves are somehow independent. But if you prime the previous cycle, the very small follicles that you did not retrieve have been exposed to the gonadotropin, and in the luteal phase, you might actually get more follicles. This is the rationale of dual-stim. But you can say, well, I primed as well in the follicular phase of the previous cycle, and then I might get the benefit of this priming with gonadotropins in the subsequent follicular phase stimulation. This we have done for many, many years. This was actually our thinking that, well, when a cycle fails, let's move quick and do the second cycle. In the poor responders, I'm quite old in this field, perhaps like some of you, and I used that a lot. And I was explaining to my patients, let's do consecutive stimulations. And then came the dual-stim protocol using, in the beginning, it was by the Japanese and Chinese group showing letrozole, and then by Italian groups of Ubaldi showing with gonadotropins, some different stimulation approach for the dual-stim protocol. And the patient actually, my personal take is that the dropout rates in our clinic with dual-stim is much lower than with consecutive stimulation. The patient feel bad after having a poor cycle. But when I approach the patient and say, listen, this is not your fault, not our fault. We are doing our best, but the situation is like this. You need more oocytes to have euploid embryos, and you don't have a reserve. The only way we can do is kind of doing more stimulation, because your ovary, whatever we do, will deliver low amount. And then the dual-stim is a way to kind of offer the patient one treatment. So our patients, the way they see it is like, we are not offering two different treatments. This is kind of one thing. And this thing will end after the second stimulation. So this is something I feel the patients are more kind of happy to have a treatment in which they know that at the end of the day, we are trying to get as close as possible to the estimations provided by the ART calculator, but we are offering treatment which is kind of dual stimulation. So we don't have data, actually, good data comparing consecutive cycles versus dual-stim. I think we need to do it prospectively, but we need also to take into consideration this other aspect, which is how the patient actually understands these cycles and the clinic. And we offer a treatment in which I can accumulate oocytes and embryos in a way that I might offer my patient the opportunity to have this euploid blastocyst somehow. And the other thing that we can do with the dual-stim protocol, and which we explore quite a lot, is actually, I tell my patients, let's start with the approach of, because they will say, well, this is more expensive. I will need two stimulations. And I say, well, your case is kind of, let's consider a patient of group 2. So the ovarian reserve was okay, but not that great. So it's borderline, because when we say the threshold is like 1.2 AMH, 5 AFC, we can have patient of AFC of 7, which is not great ovarian reserve. And the patient is still group 2. But I know that the patient will have higher embryo aneuploidy rates because she's older than 35. So that patient might benefit from adjustments, including dual-stim. So I feel that if I tell my patient, I will make the adjustments in the ovarian stimulation protocol. We will take your eggs, and then we have 5 days until we start the second stimulation in the second arm of dual-stim. Let's look into the lab and see how many blastocysts we have. Because if the embryo development is adequate, we might.
We've lost you, Sandro.
Okay, I
Yeah.
think, sorry for that.
Yeah.
Can you hear me?
Yeah, we.
Okay, I think my batteries for my AirPods are gone.
Okay. Just a couple of questions more, maybe 6 minutes more, and we'll let you go.
My pleasure. Can you hear me?
Yeah, we can hear you loud and clear.
Please go ahead.
Yeah, so Dr. Asha Rao has a couple of questions about the logistics of a duostem cycle. She says that can you do a dual trigger and then a duostem? And second question is in a unexpected poor response in a PCO woman. Dr. Rao, please ask your question. You're on mute. Please unmute yourself.
Yeah, the first doubt is about dual trigger, and then can you do a duostem?
I think you can, but our experience has not been great with that approach. I believe the first in the first follicle in the first stimulation, what we do is we give only the triptorelin trigger, the agonist trigger.
Always 2 ampules?
I mean the 2 ampules or 3. I mean between 2 and 3. The routine is 2. But I don't give HCG in the first stimulation.
Okay.
I feel that we have more hemorrhagic cysts when we start the second stimulation, when we give both. I mean the dual trigger or HCG trigger. So we stop giving HCG in the first stimulation arm. In the second stimulation arm, this is freeze-all. When you are talking duostem, is freeze-all, obviously, because we cannot do transfer after the second follicular stimulation. And then I want to optimize the FOI, the follicle to oocyte index, and I like to give the dual trigger in the second stimulation. So then I give the HCG trigger and the agonist trigger. So if you prefer to give only the agonist, only the HCG, fine, I mean, it's there. But I mean, now we switched from giving the agonist trigger in the duostem protocol, because in the past, we have been giving the triptorelin trigger in the first arm and triptorelin trigger in the second arm. So in certain patients, we feel that the FOI was not completely optimized. And then we kind of replace it with dual trigger. I don't have data, comparative data to present here saying, okay, this is better than the other approach, but we feel that the FOI perception that we have is kind of optimized by giving the dual trigger in the second stimulation.
Dr. Rao had a follow-up question.
What is the maximum stimulation? Sorry, what's the maximum stimulation that you use for this duostem?
In terms of dose?
Yes, stimulation, yes.
Yeah, the stimulation, the protocol is giving 300 units per day of FSH and 150 units per day of LH. So this is what we do for the duostem protocol. We don't go above that.
Okay, thank you.
There's a very, very interesting comment from Dr. Sujata. She says that if you're happy doing a duostem, why not do a triostem? Meaning you do 2 follow-up cycles with decapeptyl triggering and then the last cycle with the Ovitril. I think that was a very original question, Dr. Sujata.
Yeah, I think so. I mean,
because usually after we do a second oocyte retrieval, we see more number of follicles which are about 3 or 4 mm in size. So I would be, we feel like stimulating, but again, we are scared whether she ends up in some complications. So.
I don't, yeah, I mean, okay, you are, we are all experienced doctors with oocyte collection. We do many cases and complications. We only have no complications if we don't do.
If you don't do anything, absolutely.
If we are busy doctors, complications will be there. And the only thing we need to be prepared to treat the complications. But I don't feel you will kind of put your patient at higher risk if you kind of, I mean, because these patients, they don't have, let's say, many follicles to puncture. So, I mean, the oocyte pickup is quite quick. I mean, the anesthesia they get is not long. and the number of punctures will be low. So I agree with you that we need to explore perhaps a few cases with the multiple follicular waves we have. And if the patient, we have some patients here, I tell you, that they are so resilient in kind of accepting this dual stim protocol. We have patients in which they don't want to go to oocyte donation for reasons that sometimes is beyond our clinical understanding, and we respect that, and they kind of want to have stimulation after stimulation. And we sit down with this patient and say, listen, it's not possible that you are happy after 15 oocyte pickups using dual stim, and it's costly. And they say, this is, we can afford it, and we want to have chance of having our own baby. So this is sometimes very, very difficult to kind of understand, because obviously for us will be moved to the oocyte donation, please, but they still don't want. And then if you can bring something like, okay, let's do another stimulation in the quicker time frame, this is interesting to explore, because we are trying at the end of the day to provide our patients with safe stimulation that could potentially decrease the time to live birth. And then this is also an endpoint that we need to keep in mind.
I just have one last question now that we've touched 8 p.m. here in local time. One of our very senior colleagues from Lucknow, Dr. Renu Makkar, she had a question, and that's a fundamental science question, as to, do you relate the kind of stimulation that you give with the oocyte degeneration rate, or do you see any kind of a difference in the stimulation that is given and the oocyte recovery that you have? Dr. Renu, can you come up live and ask your question? So anyway, so this
can I take the advantage of that last question? In a Poseidon 5 group, can you try duostim?
So she has come on live. Let her ask the question, then I'll come back to you for the last question. Dr. Renu.
Sure. So,
yeah, we can hear you, Dr. Renu.
My question is, sometimes we see all the oocytes, they look like M2, even if they are more than 25 or 30. They look like M2, but when we do the ICSI, the degeneration is quite high. We do understand that sometimes those oocytes, those looking as M2, they may not be that ripe. That can be one reason. Is there any other reason besides technical issues? But sometimes what we see, a very well done ICSI, and even then when you transfer the oocyte, they look like degenerated and the brown ones, in spite of having very good morphology. What is your experience? Or do we have any KPIs on that?
Right. Yeah, I think it's important as a KPI. We included the generation rates after ICSI as KPI. I feel that, I particularly feel that when we have long stimulations, we have higher degeneration rates, and then we still have the M2 in the lab, but the generation rates are higher than expected. As a KPI, the generation rates has to be below 10%. ICSI. So if you have above 10%, you need to understand what kind of populations you are talking about. If PCO patients are the patients you are having these higher degeneration rates, and then in these patients, usually we give long stimulation, what you might consider is actually choosing to get less oocytes by trigger, early than later. When you get 17 millimeter in the antagonist protocol, just trigger. And then you get perhaps less M2, but there will be better embryo development in the lab. So, this is something that we discuss a lot here in patients like that. So this is something that we need to individualize. So my My perception is like, so this is based on more perception than a lot of scientific evidence. Sorry for that, but my perceptions are that we have more generation when we have longer stimulation, PCOS patients. It's kind of 10% the KPI. This is based on the consensus that we have in the laboratory. And I feel that we use ICSI a lot, obviously, I believe also in India, like in Brazil, but in certain cases in which we have high degeneration rates and the semen quality is okay for conventional IVF, we explore 50-50 in the next cycle. Because in some cases, actually, the oocyte membrane is too fragile, and just stick the needle and the oocyte turns brown and we lose it. So, I mean, in certain cases, based on semen quality, even though ICSI is more kind of the routine for every IVF center here, we kind of go a step back and considering splitting the oocytes and doing conventional IVF in 50%.
As promised, the last question, last comment to Dr. Asha Rao, and then we'll wind up.
Thank you, Dr. Rohit, for that favor. Dr. Sandro, in PCOS patient with AMH 4.6 with asynchronous follicular response, her E2 was 4,800, 9 oocytes, but only four numbers of M2 oocyte. Luprate trigger. Can we do a duostim? Is it being very naughty? You'll get into trouble with the.
Well, I think the patient has the AFC is like the AMH is over 4, correct?
Yes, 4.7, yes.
4.7, and the number of oocytes was 4.
4.
9 oocytes, but only 4 numbers are M2.
Right, yeah. I would consider doing dual trigger, but decreasing the HCG dose. This is something for you to consider. Not using the full dose, not using, if you give Ovitrel, perhaps using half of the pre-filled syringe. I don't know if you have the pen or the pre-filled syringe. Here we have the pen, so perhaps using half, which means instead of giving the 25 clicks up to the end, because each pen has 25 clicks that you can hear, listen, then you can give 13, which is half dose, although we don't have, it's important to say, any pharmacological equivalency study showing that each click has that particular amount of units. We do this fractionated shots in some patients. So if the patient is PCOS and you are afraid, obviously, of having complication, that will be most likely related to HCG trigger. In that case, I would give 3 syringes of triptorelin, and then I would give some HCG, but small dose. I would give perhaps something around 12 clicks, or that means around, because each syringe has about 6,500 international units of Ovitrel, and then you can give 3,000, something like that. And if you give urinary HCG, it's the same approach. Either you decrease to 5,000 or 3,000, and then take the benefit still of the agonist trigger, perhaps increasing the dose. And the other thing that you can do, check the other day, I mean, the LH. This is something for us to learn, because sometimes we do that. We check the next day, in case we give, I mean, the agonist trigger. We like to check in some cases in which we had not optimal results in previous cycle, to see if the agonist, because if you are keen of giving the agonist trigger for some patients, and I think all of us are these days, to use more and more the agonist trigger, in some patients with baseline LH levels, I mean, these patients have normal baseline LH levels in when we check the FSH and LH levels in previous cycles. They have normal, but not high. They have around 1.8, 2.1, I mean, LH baseline levels. So these patients, some studies have shown that 1/3 of patients with in the lower quantiles of LH, baseline LH, when we give the agonist trigger, they might respond suboptimally because perhaps the LH, endogenous LH levels, the surge that we should get after giving the agonist is not being achieved. So one thing for you to check is actually the urine next day to see the urine or even the blood to see how much you get. For you to kind of learn with your own case, this is something we do in our situation. But your question was specifically regarding providing dual trigger. And I feel that we can, and I would consider that for sure, but increasing more on the agonist trigger and providing HCG triggering lower dose.
Yeah.
Thank you.
Thank you so much.
Thank you. I think all good things have to come to an end. And today's evening promised to be an intellectually stimulating evening. And it actually turned out to be a very enriching and a stimulating evening. Thank you all. Thank you, the audience who were there till the last. I was counting till 8 p.m. The full house was there. All 34 participants were actually listening in. And that is extremely rare because we have webinars by the dozen every week these days. And thank you, Professor, for finding time out on which is still a weekday for you and enlightening us. Some very, very information, new nuggets of information were shared by you, and we will definitely try and put it into our practice. And as always, Somesh, Bharat, thank you for giving us this opportunity to interact with one of the leading lights and learn from him. I think, Somesh, you can come in and close.
Yes, sir. So thank you so much. As you said, all good things have to come to an end. So thank you very much, Professor Sandro, for joining in and for your wonderful lecture. It was really very informative and also for patiently and very elaborately addressing all the queries from the participants. Thank you very much for joining, Dr. Sandro, because it was wonderful to have you today. And
it was
also
great for me as well to participating. I want to thank you, all of you who stayed until the end, and also the questions that you posed. It was great pleasure for me interacting with you, as I always enjoy and love interacting with my colleagues from India. Thank you so much.
Great to have you, sir.
Thank you, Dr. Sandro.
And we also thank Dr. Rohit for the dynamic presence, wonderful moderation, and time for a very meaningful discussion. Thank you, Dr. Rohit, for joining, and it was really wonderful to have you two today. Thank you very much.
Thank you, Merck and team, for getting us a fantastic meeting.
Thank you, ma'am.
Yeah, and lastly, we thank all the participants who joined on the evening of working day, and they have put up all the important questions for making this an interactive one. So thank you very much for joining, and please take care of yourself till we meet again.
Goodbye. Take care.
Bye.
Goodbye.
Sandro, how are you, doctor?